Yeah.
Mr. Elder. Mr. Wicker.
Yes.
Mr. Bishop.
Here.
Mr. Masterson.
Here.
Mr. Collette.
Did Jackie say something over there? I didn't hear him. I said, here, hey, here.
We have a quorum and we can proceed. The first item on the agenda is to consider approval of minutes of previous meeting held Thursday, June 16th at 4
Motion
p.m.
approved.
Second.
The second item on the agenda is Sarah Jo Best with Lincoln Trail.
She could call a roll.
I'm sorry.
Oh,
Let's pick the game up a little bit, okay?
Mr. Masterson.
Here, yes.
Bishop.
Yes.
Mr. Wicker.
Yeah.
Unanimous.
The second item on the agenda, Sarah Jo Best with Lincoln Trail District Health Department is with us today to discuss the issues of the needle exchange program in Marion County. Thanks for coming, Sarah Jo.
Thank you. I have my handout.
Thank you.
Oops, hold on, let me make sure you got the right thing. Yes, you did. Let's just stuck two of those together.
Thank you.
Thank you, ma'am.
Papers are sticking together.
Thank you, ma'am.
All right, so when I talk about, the Kentucky Needle Exchange programs are called harm reduction and syringe exchange programs. There's just a little preface in case anyone doesn't know this. Lincoln Trail, I'm the public health director for Lincoln Trail District Health Department. The Lincoln Trail District Health Department is a regional public health facility that services the health departments in Hardin, LaRue, Marion, Meade, Nelson, and Washington counties. So we serve a 6-county regional area. The harm reduction syringe exchange programs are the title that Kentucky, when the legislation passed for this, that is the name they gave to what you're seeing in the newspapers called needle exchanges. I have to start by giving you a little bit of background about harm reduction syringe exchange programs, because these are some of the common misconceptions when I talk about this. This is not going to stop drug abuse in Marion County. It's not the end all to that. I like to think of it as a wagon wheel when we're addressing drug use and drug abuse in our communities, and a harm reduction syringe exchange program is merely one spoke on that wheel. It does not negate the need for things like law enforcement and prevention of drugs coming into our community. It does not negate education and early intervention. It doesn't negate the need for resources to build strong families. It doesn't negate mental health services and all the different things that go on that wagon wheel. The other thing I need to make sure that you understand is that public health is coming at this through one of our basic services that we do, which is epidemiology. And what that means is investigating and controlling the spread of communicable disease. So when we talk about harm reduction syringe exchange programs from the public health perspective, we're talking about programs aimed at prevention of communicable disease, particularly HIV and hepatitis C, that are associated with the sharing of needles and improper disposal of needles. Public health also very much focuses on the prevention side of things. So our first step in any program that we do is to try to prevent. Because if we can prevent disease or injury in any of our programs, we know that that's better for the quality of life for the individual, and it's also cheaper as far as healthcare expenditure costs. The second step that we move into, we couldn't prevent it on the front side, and we do a lot of education in the schools and in our community trying to prevent the use of drugs. We can't prevent it, and we try to mitigate or minimize the damage, just like we would if we did diabetes. If we can prevent someone from getting diabetes, that's going to be our first initiative. If we can't, then we're going to try to help them control their diabetes so that we don't have amputations and vision loss and things like that. So this program is very much public health driven in the fact that we're looking first and foremost at prevention of communicable disease spread, and two, for those affected and already testing positive for HIV and hepatitis C, that we prevent further spread and minimize those numbers. So if you'll follow along with me on your handout, harm reduction syringe exchange programs are comprehensive programs designed to provide safe disposal of needles for injection drug users, or IDUs, is the acronym that's used for that. And so these create a common place within the community that people can safely dispose of their needles. That gets them off the streets. It gets them, and they're incentivized to do that. So they're going to get a clean needle in exchange for their dirty needle. And so they're incentivized by that to bring those in so that we can dispose of them properly. It also provides a venue for testing for blood-borne viral infections for those at high risk. So injecting drugs makes you high risk, lots of risky behaviors associated with that, but it does increase your risk for contracting HIV or hepatitis. And so you may not seek out testing for that if you're not visiting some type of facility like this. Supplying clean needles prevents sharing, which prevents sharing of infection as well. The injection drug users also have a resource for treatment and social services that they may need, and so this is not something that public health does alone. I was talking before the meeting, we look at creating partnerships with substance abuse facilities, with mental health facilities, with community partners that may deal with resource needs, treatment needs, signing people into insurance, those types of things if they've went those labs, so we can possibly get them into treatment. So it's a process, it's not a given. I'm here today just to do education and just to begin discussion with it so you have a little bit of background. I'm not asking for a vote today. We're in the assessment process at Lincoln Trail District Health Department. We've been doing this in each one of our counties. This is the third of 6 fiscal court meetings that I've gone and just talked to them. We've also done this with our governing board of health and talked to them about the information that affected those 6 counties. We've also done some talks to different community groups, and we've also brought in community partners from each one of the counties that we serve to begin talking about what they're seeing, trends. We've invited people like solid waste. What are you finding on the roads? Are you getting complaints about needles found in your community? Mental health facilities, drug treatment facilities, ERs. What are you seeing, in ERs? Law enforcement. What are the trends? Are you seeing heroin? Are you doing are you doing drug arrests related to heroin? So that's where we are, so that you are here. Assess the need for a harm reduction syringe exchange program that needs assessment. We also have to assess the readiness of the community, and that's why I'm really starting out with education, because it can be a very controversial topic if you don't understand the why behind it. And I'll be really honest with you, if you had asked me, I've been in public health for 14 years now, if you had come to me 5 years ago and said, the health department is going to hand out needles to injection drug users to prevent the spread of disease, I would have never believed you. So this has been a process for public health officials too, to really, to see the research, to study it, and figure out how we need to approach that. We have to be ready for that because there is an approval process. The first vote that we would have to obtain is from the Governing Board of Health. So you have representatives from Marion County that serve on our Governing Board of Health. We have representation from each one of those 6 counties based on population, and they meet quarterly, and they are responsible for what the health department does, for our finances to our programs. And so the first vote would happen there if they want to do that. The second vote is if they said yes, and a county wanted to have it in their community, it would have to come to fiscal court, and it would also have to be voted on. If it's going to operate within city limits, it also has to go to the city for a vote. So there's multiple processes, multiple layers, and education that really needs to happen before you do that. And you need to build community support. We can't do this without our community partners involved. So the next page 4, I wanted to talk to you about what other health departments are doing across the Commonwealth of Kentucky. CADA did a survey, and CADA stands for Kentucky Health Department Association. It's made up of all the public health directors like me across the Commonwealth of Kentucky. So there's 61 of me across our 120 counties. 93% of our membership responded, which was 180 counties. 74 counties are actively engaged in promoting syringe exchange programs. So on some level, they're either going through the assessment, they're doing community talks, or they're actually going for votes. Among those, 34 counties are not currently promoting syringe exchange, but of that, 11 counties plan to promote it in the future, so they just weren't there yet. Among the 108 counties, only 24 had no intentions of crossing this bridge whatsoever. And that was in January. It takes time, so I don't know if any of those have changed. There are 12 harm reduction syringe exchange programs currently. There's one that's getting ready to be approved. But so far, Jefferson, Fayette, Pendleton, Carter, Grant, Jessamine, Franklin, Knox, Boyd, Clark, Harrison, and Kenton counties are doing syringe exchange programs. All right, so let me tell you what is not true before I tell you what they can offer in the community. There's a lot of myths that go with this, and a lot of them are based on unknowns or fears. But syringe access programs are not enabling. They do not encourage individuals to begin using drugs. Just because of a need, we're not handing out heroin, we're not handing out, meth. We're handing out a syringe, and that does not. We're not promoting drug use, but we do want to do it. We do want to minimize the spread of infection so that we don't have sharing of needles. So just because a needle is available does not make someone initiate drug use. There's much deeper rooted reasons why individuals turn to drugs. It does not increase drug use among existing users. So they're going to use, whether they have to share a needle, whether they have to use a dirty needle, whether they have to go to the local TSC and buy a needle for an animal, whatever happens, it's gonna occur, whether or not there's a clean needle. And that's the problem that we're seeing in areas like Indiana, and why we're seeing disease outbreaks. It does not increase crime in neighborhoods in which such a program operates. There are many scientific studies, including the Surgeon General's report, showing that syringe exchange programs do not increase drug use when conducted with referrals to both drug treatment and HIV and hepatitis C testing, medical care, and support services. Benefits of a harm reduction syringe exchange program. One of the most beneficial things is savings. And this is the part that to treat hepatitis is very, very, very expensive. A needle is not expensive. We buy needles in bulk. This is not an expensive program. It's not an all-day long program. It doesn't require a highly qualified staff to do that. You have a health educator, typically, and an alcohol and drug treatment counselor there. It's typically later in the afternoon. It's not intrusive. So it's not a huge cost to do that. It does save dollars by reducing HIV transmission among injection drug users, so treatment costs go down. Advancing public safety, including the safety of law enforcement officials by taking contaminated syringes off the streets, out of parking lots, parks, school grounds, and playgrounds. We're seeing that more and more. It serves as an important link to mental health and addiction treatment services. It serves as an entry point for other healthcare services. So some of the co-services that can go along with that are referrals can be testing for HIV, hepatitis C, pregnancy testing, sexually transmitted disease infection, providing vaccinations, overdose prevention kits, education and counseling, and other health department or other healthcare provider services. And it's providing cost-effective interventions compared to treating those diseases. The next slide, I know this is really busy because it's little, but there's so much research, and that's what I wanted to show you, where they've watched these harm reduction syringe exchange programs. They have been proven to prevent the spread of HIV, hepatitis C, and other bloodborne diseases. The cost of providing the hepatitis C treatment that I was talking about earlier ranges from $84,000 to $300,000 per person. That's one person. That's a whole other discussion of why is that so expensive, and aren't we shooting ourselves in the foot with that. But the cost of preventing drug-related infections is 150 times more cost efficient than the cost of preventing drug-related infections is 150 times more cost efficient than the cost of treating disease spread by infected syringes. The next slide talks about preventing HIV infection in people who inject drugs also prevents HIV in pregnant women and newborn children. So if we can do testing, then we can find out if they're HIV positive, If they are pregnant, there are treatments for that where we can prevent the spread of that to the unborn child. And we can refer and do that. We can, a lot of times too, that's another venue for treatment services. They find out they're pregnant, they're using, and they may go into treatment services, and we may be able to mitigate some of the damages to the child when it's born. So Kentucky hospitalizations for drug-dependent newborns increased from 28 in 2000 to 824 in 2012. Hospital charges for drug-dependent babies in Kentucky in 2013 was $40.2 million. So there's potential to help save both quality of life for those children and also healthcare expenditures. The next slide has to do, so on page 9, we're looking at studies that show harm reduction syringe exchange programs not only increase the likelihood of individuals seeking treatment, but also decrease risky behaviors associated with IV drug use prior to obtaining treatment. So even if they're not willing to go into treatment yet, by having that rapport with the individuals that are working that program, it has been proven over and over again that they will decrease risky behavior that spreads disease. Studies are showing that the people that use these programs are about 5 times more likely to enter into treatment than people that don't. The program meets the individuals where they are. One of the other things that I went to the Louisville Metro Exchange to see it, and one of the things that they also talk to the individuals about is just taking care of their skin. There are secondary infections that happen when people don't know what they're doing or that they abuse injection drugs, which also increase healthcare expenditures, and they end up in our ERs for things like skin infections, abscesses, collapsed veins, sepsis, where that infection gets in through the blood. And typically they say about 5 days longer than someone without a drug-related issue in the hospital, so that the hospital expenditure cost would be much greater. So the next slide talks about your second packet that you have that has Marion County specific data. Kentucky, one of the things you need to know is Kentucky leads the nation in acute hepatitis C rates. The Kentucky rate doubled from 2010 to 2013, so we have an issue with hepatitis C. We also have a major issue with drug use in Kentucky, and we also, out of 220 counties identified by the CDC, 50 counties in Kentucky are at risk for an HIV outbreak. None of our 6 little counties were in that, but we are surrounded by that. So what does that tell me as a public health official? That it's on its way. Half of all acute hepatitis C cases in 2014 in Kentucky were in the 21 to 30-year age group, with IV drug use being the main risk factor. And so that's where we're seeing the most increase in our hepatitis cases, are in that age bracket from 21 to 30 years old. And then you can just see Marion County hepatitis C rate is below the state rate, so that's good. And it's also below the Lincoln Control District Health Department rate. Drug-related inpatient hospital discharges and ER visits have continued to increase for Marion County residents after 2012, and a total of 169 drug-related inpatient hospital discharges and ER visits were documented by Springview and H&H from January 1st to September 30th of 2015 for Marion County residents. The next slide shows you the Louisville Metro Exchange. They are tracking zip code to see where folks are coming from to use their program. And so I asked them for that information, and you can see that a lot of the counties in the Lincoln Control District Health Department were utilizing that program. That's kind of old. That was back in January, so I need to get more recent information, but I know that that's probably grown since then. The other thing that I attached to the back is a little headline about a hepatitis C newsletter that we get from the state. I thought that was very interesting, that we were highlighted, that 220, remember I said 220 counties of more than 3,000 in the United States were at risk for an HIV infection outbreak. 56% are in Kentucky, Tennessee, or West Virginia. So we're disproportionately affected by that as well. So, any questions for me?
I've got one, simple as it may be. As far as the needle exchange, I know Jackie's got a problem. How many needles can he get?
How many can you get?
Yeah, do you just get one needle or?
Well, that depends.
Well,
It depends on how you set it up. Some of the programs are set up 1-for-1. You bring me 10, you get 10. Some of them are set up that the first time that you visit, you tell me how many you're going to use in a week. You only get a 7-day supply
Right.
because we want you to continuously come and have interaction with us. So whatever that 7-day supply is going to vary from you to you. You may use 4 times a day. You may use 10 times a day.
Well, I'm assuming, is it like doctor-patient privilege here where this discreet? I'm assuming. Yeah.
Actually, what they're tracking is merely zip code, and they assign a unique identifier that has nothing really, you can't track who that was.
Yeah, I'm not gonna need any, but I'm just, if somebody does want to do it, they would probably prefer to remain anonymous, I would think.
Is
And
this,
that's why they're set up.
is this set up at health department, or where do you?
You can set it up different ways. Louisville Metro Health Department at first did a mobile unit outside of the health department. That got a little cramped, and they moved it inside the health department. There's a county in Kentucky that there's kind of a one-stop shop for resources. It kind of has Feeding America, and the Salvation Army, and those type, like all kinds of one-stop shop deal, and they have this in there as well. It works best in rural communities when it's grouped with other services and not standalone, because when it's standalone, everybody knows why you're there.
Yeah.
If it's grouped with other services, you could be there for something else, you could be here for this, that, or the other, and nobody really knows. So in rural communities, it does work better when it's grouped with something else.
How many needles are you all seeing in rural areas that are getting exchanged?
Well, right now, we're not operating a needle exchange, but when you do have to track that, and you actually, the health departments that are doing that are actually tracking that and reporting that to the legislators. They want to know how many they received, so how many did you take in, how many did you give out, because they want to compare that number, how many referrals into treatment did you do, how many positive testing, and so they are tracking that data where the programs are existing. I don't have that, it'll be different for every community, but they are tracking that and reporting that. That would be a requirement too if we did this.
I'm assuming at the time, we don't have any kind of a cost projection.
It's tough because you don't know how many people are going to utilize
Yeah.
it. So it's your best guess when you start, and then after that first year, you have a better idea.
Is it like any kind of like a per person formula or something? I don't know. I'm just curious.
No, not that I'm aware of. I will say, currently, we do not have state or federal funding to offset this cost. It is something that the local health departments will have to use their local public health tax dollars to do. But communicable disease control is a mandate for us, so it does go along with our mission. But there are grant dollars out there, and so we have talked to some of our community partners that participate in some of our ASAP councils. And so we are creating partnerships to try to go in and do it more as a partnership, and so the health department doesn't bear all of the responsibility and all of the costs.
I mean, it's reality. We have it in Marion County, just like every other county, and, it's something that needs to be addressed for sure. I don't know how much support. It sounds negative from, like you said, 5 years ago, you wouldn't even dream that this would be an issue at the health departments or anywhere else, but, it is in our community, so it's important we do something about it, so just let us know what.
If you have questions later, my contact information, you have my contact information, I'll make sure that you call me for them. Or at least when you can call me or send me an email or whatever, and I'll answer your question, but I may be able to give you more detail information about your question.
Thank you.
Okay?
Thanks for your time.
Thank you very much.